It's getting to the point where I'm no fun anymore. I am sorry. Sometimes it hurts so badly I must cry out loud. I am lonely. I am yours. You are mine. You are what you are. You're like
Buddy, so this is part 2 of the lecture on lithium. Hopefully you all will see part 1. Please email me or whoever's at your local site if you need a copy of the handout or the slide, which can be sent to you as a PDF. Just focusing on mental effects with a heavy dose of renal pathophysiology, because for most people this is often the biggest barrier or source of concern in prescribing lithium long term. I hope it's the case last time that lithium has unique abilities of reducing suicidality. Many of you know it works for depression. Of course, it works for mania prophylaxis. But the burden for many people is the concern about the long-term renal adverse effects. I'm going to talk about the more common and what I'll call benign effects, which I think can generally easily manage with a couple of exceptions. So the one is tremor. This is not unique to lithium. We see it also with valproic acid as well. This form of tremor is very distinct from ET. This is really an exaggeration of the normal physiologic tremor. It looks like they've had too much caffeine, and it's managed in the exact same way as you manage an essential tremor. So if you reduce their level, because they need that certain level to maintain stability, then you add propranolol. And of course, propranolol crosses the blood-brain barrier. No point in atenolol, it's probably not going to do a whole lot for them because it doesn't cross the blood-brain barrier. GI stress is often related to the immediate risk preparations, which are used by the majority of patients. I would say 95% of the patients treated with lithium are on regular old lithium carbonate. But the people for whom that lithium ion bothers their GI tract. And these are the people in whom I will suggest going to a sustained release preparation. As I mentioned last time, and I'll show you some data later on, using sustained release preparations or giving lithium multiple times a day causes more long-term renal adverse effects, specifically polyuria. The majority of patients should be given regular old lithium once a day. It has a CNS half-life of 28 hours. But in people who are very GI sensitive, we'll switch them to a long-acting preparation given once a day rather than having them just stop lithium completely. Hair can be a difficult problem at times. I give you information about using vitamins, specifically those with selenium and zinc. The problem, not mentioned here because it wasn't available and it may not still be available, is the use of minoxidil. And it really does work, and this is a formulation for both women and men. It may not be a formulary medication, and you, of course, may have to fight a little to get it approved, but it's going to be the patient's sticking point in taking lithium, and of the multivitamin does not solve the problem. It's worthwhile battling for that if it allows you to keep them on lithium. Taste is a unique problem with lithium. It doesn't happen a lot. I try to lower the levels a little bit. I haven't found any other solution to this problem, but it all somewhat like tremor is level-dependent adverse effect. And so 0.9, they're complaining about this. Try to run them at 0.8, 0.75, and this will work out. This problem, I think most people are familiar with. It will cause some acne-like problems in people who don't have acne or very little. If they have an existing problem, it can often make it work like psoriasis. There is a good solution if it's an exacerbation of an existing problem. If it's acne, though, you can treat it with the usual methods, both topical and occasionally systemic antibiotics. The number of topical agents, benzoyl peroxide, vitamins, all of this sort. These are all valid options. Actually, though, it becomes bad enough that you simply do have to switch them. I know one job I had existing psoriasis, which wasn't so bad, but it got worse on lithium and just wasn't going to work out. problem with all of the medicines we use, and as you see, my comments there are good luck. We don't have a great solution to this problem, but not unique to lithium. Depakote causes the same thing, so it's not as though you're gaining anything by switching to valproic acid. First is probably related to the fact that lithium ion gets in the same places as sodium, and they hang out there a little bit longer and cause peripheral edema. And so for these people, we can trust reduction, but I've often found that actually increasing their salt intake helps a little bit. So salt will replace the lithium and get into some of these places, but it gets cleared a little more readily and does cause the peripheral edema. So this is something which people see not uncommonly. It's not usually a source of major concern, but there often are benign changes on an EKG. So you'll T-wave flattening, sometimes T-wave reversal or appearance of U waves, which is related to electrolyte depletion. It's not a cause of concern. It's a phenomenon that's seen in people on lithium. What people do get concerned about, and this is usually in overdose situations, is development of bradycardia. I was up at Atascadero a couple of weeks ago, and they presented actually the case of a gentleman who did this at therapeutic levels, and I'd never heard of that before. There are people who may be uniquely sensitive to this, but for the most part, it's a phenomenon you're only going to see in situations, or if somebody already has sinus node autoticity problems. So you may very much, the people actually saw it at one guy at therapeutic levels, but it typically is an issue mostly in overdose situations. So in routine EKG monitoring is usually not recommended in people who are young and healthy. If you're an older individual, someone who's known to have perhaps some sinus node problems, that's fine. I have no objection to that. That's reasonable. But if you have a 24-year-old who's going to be on lithium, there's nothing to be obtained in routine EKGs. Thyroid effects, I think this is really a non-issue for most people. It's one of the most poorly managed of all lithium-related adverse effects. If there is no ceiling in terms of exposure, if you're on it for 20 years, you don't have it, does that mean you'll ever get it? Maybe not. So that's why we monitor TSH throughout the lifetime of somebody on lithium. It's never a reason to stop lithium, and hypothyroidism is never a reason to avoid lithium. Thyroid comes in a whole bunch of doses. It's very easy to give people more if they already need it, and didn't need it, and now they need it. You started out. Either problem, usually a non-issue. But it does require ongoing monitoring. So, lactation can represent serious issues or maybe confusing issues for a lot of tropic medications, again, not unique to lithium. And so I made up this slide a few years ago. It was that lithium increased the risk of Athens anomaly about 8-fold. It's pretty rare on lithium. We're talking 1 in 2,500 people. So it is still pretty rare. And I think a lot of folks felt that the benefits outweighed the risks if you had to treat somebody in the first trimester with lithium. Alternatives, that's always great, but Depakote is not going to be one of them. You probably figured out from its FDA during pregnancy. It's always a risk-benefit decision for the individual patient. If you have somebody who really does need lithium, and it must be continued to avoid manic exacerbation in her first trimester, you are increasing the risk some, but the risk is still very, very small. And most people say it's a risk that can be managed through ongoing echoes of the fetus, just to see if something develops. So sometimes happens is during pregnancy, women develop polyuria through various hormonal reasons. And of course, you do want to maintain an eye on the electrolytes. Like we discussed before, if you become sodium depleted, it can reduce lithium levels. So you just want to make sure that all the electrolytes stay normal throughout pregnancy so that you can keep what they need in terms of lithium exposure. And so people have recommended, based upon some of the data on APGAR scores, that probably lithium should be discontinued 48 hours before delivery if it's a planned delivery. If it's planned delivery, I think most people would say as soon as you're starting to develop significant conditions, okay, this is going to be an imminent event, start on the lithium. So today's lithium level is as close to zero at the time of birth. Lithium resumed after pregnancy. Have data, as I have in the fourth bullet, on parents who are on lithium who are breastfeeding their infant. And what is that? If the mom's average lithium level was 0.76, it's going to be 0.16 in the baby. So some exposure is about a fourth or a fifth of what it is in the mom, and that level of exposure, as far as we know, has not been associated with any adverse events. So it is something which will be some transmission into breast milk, but we think that the low level of exposure isn't necessarily going to cause problems. But if I was a pediatrician, would I want to check maybe a white panel or GFR on the infant? Yeah, why not? Why not do that once a year just to kind of see if there'd be any adverse effects? The latest on this actually comes from some large observational studies looking at incidence of overall adverse women in various sites in Australia, Israel, and Toronto. So this got published in July 2014, American Journal of Psychiatry, 12 months ago. Large sample size as far as these types of studies go. One thing was that there was an increased incidence of miscarriage, which was statistically significant, but significant difference in overall adverse birth outcomes. Logistic model, what they found was exposure to lithium did increase the risk for cardiovascular anomalies, but it was only 4.4 times. And the number, which I cited, of 8-fold increased risk has now been modified somewhat lower. So I thought you would say there probably is some increased risk of Epstein's anomaly and other cardiovascular malformations in first-year exposure, maybe not as high as we thought. And so 4-fold increase, so instead of 1 in 20,000, which is a baseline, maybe now it'll be 1 in 5,000 or 1 in 4,000. So still a low incidence, but some increased risk. But now we have a revised number, which I think most people would say is probably the best data that we have out there. So again, always a risk-benefit discussion. If you can't, like to minimize first trimester exposure. If you can't, this is the best data about advising a woman and what the risk might be to the baby. As people would say, if the woman's going to continue lithium in the first trimester, managed, or perhaps managed, I should say, by ongoing echoes of the baby to see if there's any cardiovascular problems which have developed. Are hypercalcemia, which you may see from time to time, and is intracranial hypertension. But the hypercalcemia will pop up once in a while. Most say if the calcium is trending up, eventually you can check the ionized calcium, because it's the active ingredient, so to speak, just to see if there really is something that needs to be treated. It needs to be treated, then you can refer them to the endocrinologist for management. Does it come down to this person needs a hyperparathyroidectomy? You would manage them the way you would with anybody with hyperparathyroidism if the calcium remains persistently high, and start getting adverse effects like stones. So fortunate in our setting that we rarely see acute lithium toxicity. But the time we see it is often precipitated by drug-drug interaction or acute dehydration or things of that sort, essentially from overdose or accidental ingestion. And people do get higher lithium levels. The thing we get continually is bradycardia, and that's why these folks will go to enter bed when their levels are above 2. Below 2, you necessarily even have to send them to an acute hospital. Hospital settings, most of these places will not even pay you until the lithium level is 2.0 or above. You can recognize area of concern on levels below 2. We'll get to 2 and above. Most people are starting to worry about the bradycardia. And the level was 1.8 if the person was bradycardic. You probably send them to a monitored base to make sure. Your levels get higher and higher. You start to see cortical depression. You start to upper motor neuron signs, cerebral signs as well. The overall description based upon your serum level. So 0.5 to 1.99. Typically would just say hold their next dose, or maybe the dose after levels, and then resume with the safe, obviously at a lower dose, or if there was a kinetic interaction, remove the offending agent, and then start over again. As you get to levels 2 and above, you're going to go to a monitored bed, supportive measures, and 3 and above, you're going to get dialyzed. So the long-term toxicity has been described in a number of cases. As you get to levels of really 3.2 and above, you may have some permanent sequelae. I can think of any time since I've been here in the last 5 years we've had a level that high. The highest level I've seen has still been below 2. And at very high levels, death could be an outcome, but I've not seen that. These are the permanent things which you might see with people with very high level of exposure. Typically, get actually a cerebellar sign. It's not really a cortical problem. They don't become demented. They tend to have ataxia, or dysphoria. So it tends to be a cerebellar problem. They're probably not happy with it, but it's nice that they're not demented. They didn't have any other respiratory arrest or other problems. One you can see there did have memory impairment with a 4.8. Some others have some upper motor neuron signs with hyperreflexia, but portal permanent sequelae are very rare and not seen commonly at all. About the kidneys. Lithium is fully filtered and about 8% is reabsorbed in the proximal tubules where it competes with sodium for reabsorption. So this is when people become lithium depleted, let's say through diarrhea or excessive sweating, they can become lithium toxic because then the lithium will be preferentially reabsorbed, not enough sodium in there to compete. So that's why in places where it's very hot, like here at Patton, we close the yard when it gets to a certain temperature. There's others as well, but this is one of them. We don't want people to sweat a lot. It might be on lithium. This is competition with reabsorption of CM in the distal tubules, and we'll talk about how that is. So there's a lot of ways to increase lithium levels. Hyponatremia being one common one. In terms of drug-drug interactions, which we've tried very hard to stamp out, is the use of prominent medications, particularly among the ACE inhibitors like lisinopril. All will bump up lithium levels to some extent, but lisinopril has proved itself to be uniquely dangerous in combination with lithium, because lisinopril is the only ACE inhibitor which is 100% renally cleared. And so ACE inhibitors, which are the most part hepatically cleared, lisinopril is very susceptible to kinetic alterations in people whose renal function might decline, which folks who are on medicines like lithium. And I found very quickly, I give you the reference down below there, I was at the VA hospital where they switched everybody from lisinopril to lisinopril. The drugs are not therapeutically equivalent if you're on lithium. We put a first people in the ICU who would well on lisinopril but could tolerate lisinopril. And pretty much ban this combination. If we ever see it, we ask the med-surg physician to switch them to any ACE inhibitor. It's not all equally bad. It's lisinopril is uniquely bad, and all others are much safer, much safer. There's no unique benefit in this particular inhibitor. There's really no reason to preferentially use it in people on lithium. And you can use inhibitors. We understand ACE inhibitors have a lot of benefits for renal function if you have people who are dysmetabolic, and that's fine. But one medicine that should really never be used, there's no reason to use it with lithium. There are no unique advantages. So an ACE inhibitor, do anything, but don't give them this one. Also increased lithium levels, a lot of the distal loop drugs, including the potassium-sparing diuretics, certainly the non-steroidals as well. Things appear to be relatively safe. The loop diuretics, like furosemide, have a lot of effect on lithium levels, and aspirin also does not have a lot of effects. And so you have somebody in whom you have to add an ACE inhibitor, so don't make it lisinopril, and say it is benazepril or something else. That's fine. Just recheck their lithium level in a week and adjust the dosage. It's not a deal. You can do it. You can do it safely. You just have to have enough sense to not pick lisinopril and check the level in a week on the other ACE inhibitor and adjust the dose accordingly. So how does lithium cause some of its problems? Well, polyuria for most people is going to be the most common renal adverse effect that they will complain about and that you will see. So what are the distal tubules? There are what's called epithelial sodium channels, or ENaCs, where their job is to reabsorb sodium, and then it goes through these channels, and then it goes out the basement membrane through the sodium-potassium ATPase pump. So actually, lithium is a better substrate for the ENaC than sodium is itself. It gets in a little bit easier. And what happens is lithium gets in, but the problem is it's a poor substrate for the sodium-potassium pump. It's a cell, but you can't get it out the basement membrane because that pump is not going to be picking up the lithium very well. And you become locally lithium toxic. Those cells start to develop high intracellular lithium levels. This accumulation in the cell has untoward effects. In particular, it's going to inhibit enzyme GK3 beta, which may be part of its therapeutic mechanism in the brain. But these cells actually cause them to start to become very sensitive and down-regulate the water-absorbing aquaporin channels. This is the lithium builds up in the B12 is to downregulate, and you start to become sensitive to water absorption because you hear your vasopressin signal while you develop polyuria. So some like the physiology I gave last time, which I'll use again to picture how this is lithium is the bad party guest, okay? You invite these sodiums to your party, but lithium comes in and kind of crowds them out at the front door. So they barge in at the front door, they barge in at twice the rate of the sodium people, and they drink all your beer, they inhibit the K3 beta, and then you can't get them out the back door. You get them out the back door through the sodium potassium pump, they won't leave, and they cause ongoing problems. And that's exactly what happens here. So the question is, of course, what can we do with this? And I will tell you a little bit later. People on lithium in terms of renal function. So labs now will actually give you an estimated GFR, and this is the parameter you should use to monitor renal function. Threat is useless. You know, my name might be the same as somebody who's 20 years old, but I can tell you have very different renal function. And so estimated GFR, which tells you what the true renal function is, and that number that you should use to monitor people on lithium. I'll reference for a site to look to calculate your own GFRs if your lab does not give it to you. This is the number you should track. A normal GFR is greater than or equal to 60. You know, for people who are young and healthy, it may be well above 100, but anything 60 and above, most people don't get too excited about. Then you can track if you're monitoring for polyuria is urine osmolality. It's 24-hour urine collections. People cooperate with this. They get up in the middle of the night to urinate. They forget to use the jar. And so you never get the volume that you think you do. Sometimes you have people who are very cooperative. You'll get it. But even cooperative people forget. It's 2 in the morning. They're tired. They're on meds. You know, they step down to the bathroom and you've lost some unknown volume. And so the easier way to go, you get what's called a spot urine osmolality. And then you have the normal numbers here. Some may have slightly different numbers, maybe 700 is the upper limit of all, but it's going to be roughly in the ballpark. And people who have significant problems with polyuria will have nephrogenic diabetes insipidus, and their urine osmolality will be quite low, well below 300. I've seen about 80, 90, 100. Whereas it may, it's not a problem. They'll probably have levels in the high partial NDI range or the normal range completely. No, it does creatinine clearance, and as I said, 24-hour urine volume is just impossible to do, and I wouldn't have time. Even in a patient setting, you say, I have high functioning, you know, people who work and all that. Keeping your urine in jars for whatever reason, and it's for them to do. A spot osmolality is much easier to do, even for a high functioning person. You need to follow also if you want to get an update. So you've got a 24-hour urine collection, then maybe you're going to treat it, then you're going to have to do it again. And spot urine osmolality is just a much easier way to go. A lot last time about how there's been evidence that multiple daily dosing has more long-term renal adverse effects than single daily dosing. And really the first study that proved this. This is published by Moen Scout, the famous Danish psychiatrist who did all of the early pivotal studies on lithium after the initial early experience in Australia. He's the first placebo-controlled study, the first double-blind study. I mean, he's the one who really proved lithium does what we think it does. So he looked at these 2 clinics in Denmark who had very different practices with the use of lithium. One immediate release lithium once a day, that was in Copenhagen. This slow release lithium twice a day, and you can see the kinetic curves here. The people at the immediate release, of course, you have a high peak, which occurs when the folks are asleep, so they don't notice it. But it tends to be a bit lower in the latter half of the day, where they're getting the BID dosing. They tend to have lower peaks. Their trough is higher throughout the day. And we capitulated that it's this high persistent trough in lithium multiple times a day that results in more long-term adverse effects. And the biggest thing you get is polyuria. So it's a table. If you just look at the log, it says urine volume in liters a day for the BID dosing. Their urine volume was 2.8 liters per day. But the people regular immediate release once nightly dosing, 2.38 liters per day. So a liter more. This after only between 6 and 8 years of exposure. Long half-life in the CNS, 20 hours. There is no reason to have anybody on anything more than once daily dosing, with the exception, which I gave you, of people who really have GI intolerance. And then fine, give them a sustained release preparation. But even then, just give it to them once a day, okay? Because we let them on lithium, they're not on lithium, and we'll just take whatever lumps we get with sustained release preparation. But people who are on lithium should always be given multiple daily dosing consolidated at bedtime. And some people say, well, the first couple of days, I want to make sure they don't have a GI problem. Fine. For that first couple of days, that's it. Time to consolidate it, put it all at bedtime, and then just kind of go up from there. So study, and what you see is that over time, at least, doesn't seem to cause significant changes in creatinine clearance, but you see a little bit of polyuria kind of creeping in, and concentrating ability you see going down a little bit, which is in the bold-faced type thing. So their urine osmolality went down from 845 to 764, the normal range, but you see a little bit of that. But at least 7 years, most people are not experiencing significant changes in creatinine clearance. Small sample, people who they're able to follow, 9 of whom were on lithium for 20 years, and what they showed is that the people who had once daily dosing actually had lower creatinine, significantly lower creatinine than people who got multiple daily dosing. So small sample size, and giving people lithium multiple times a day is not good for the kidney beans. There's no difference in efficacy because it's seen as half-life of 28 hours. So there really is no point in doing this. So urinary volume really remained stable after that first decade. And here we have some people who were followed on average, 13 of them had 20 or more. You start to see again some effect with long-term exposure, again on urinary volume. But it's a full size, and so I think people would say this didn't answer the question. So for this, the folks in Israel published a study 10 years ago, which I think is wonderful. This is the largest sample that I've seen of people who've been with lithium. Follow-up is almost 17 years. You'll see there have been some people who were on lithium for 30 years and more. 100 people, mean age of lithium initiation was older. These are people who started in their 40s, so they might already have reasons to have some renal dysfunction due to hypertension, diabetes, things of that sort, and there are long-term effects. So criteria in this study 10 years ago for saying somebody had renal deficiency was a creatinine of 1.5 and above. If they had redone this study today, they would use estimated GFR, because it's more accurate than creatinine. But this was the threshold that they used in saying this person is having some renal insufficiency. What they did, almost 80%, even after this long-term exposure, did not meet the criteria for renal insufficiency. A group of people who get more than expected increases in creatinine, or perhaps a better way to say it, if they had calculated it, would be more than expected decreases in their estimated GFR. And so people for whom they do have some problems, and that's why you monitor people, just so you can ferret out the 1 out of 5 folks who might get more creatinine creep or estimated GFR decrements compared to the average person. But the real aspect of this is that 80% of people are really not going to have significant changes in renal function. It's polyuria, and that'll be something which will be a nuisance and may have to be managed. But in terms of loss of GFR, not to be expected for the majority of people on lithium. And further analysis, they said, well, who were among these 21% who got unexpected increases in creatinine? Who were the people? And these people, 40% had diseases which impair function, like hypertension and diabetes. Not advised there, but it does alert you that if you have somebody with hypertension or a reason for renal dysfunction, like diabetes, these are people to watch very carefully. These are the people who may have some deeper GFR to the point where you actually have to take them off of lithium. Risk factors for their renal insufficiency was the dose, or the level, or the gender, or the age at which they started with the psychiatric diagnosis. So these appear to be relevant. You should give people the lithium at the dose and the level that they need to keep them stable. Lower it may help manage certain adverse effects. It's not clear it's going to have a big effect here, though. So if somebody might have polyuria and your level of 0.75 to be stable, lowering their level to 0.6 is probably not going to make the polyuria better, but probably will make them manage. and have to find other ways to manage it. But lower is not necessarily going to improve this problem. And I hear this term used, I think, inappropriately, that, oh, I'm worried that my person's going to get renal failure. And to correct people, I say lithium as a cause of renal failure is a thing of past. And I have two data sets which show that. It was reported in the early decades of lithium. It only started to be reported as people get into the 90s and above. And what I'm to recognize, the incidence is very, very small, but the addicting value in who did end up on dialysis, they had terrible renal function to begin with. Probably these are people in the modern age who never would have been on lithium. So what happened was, as lithium gained more widespread use in the 70s and 80s, you had a bunch of people who were giving out, perhaps indiscriminately, attention to that fact that this person has perhaps very low renal function to begin with, and I want to put them on something else. Now, in the 80s, people didn't know about that, but they had no alternative, and I understand that. But now they have alternatives. I think a lot of these people would never have been started on lithium to begin with. This paper came out because would use of lithium with modern treatment monitoring principles. 6 months, the UN creatinine, calculated GFR, or end up on dialysis. And so Sweden, they started modern monitoring principles in 1980. And a registry of almost 4,000 lithium treated people. They found 30 folks in whom lithium treatment was the sole or main contributing cause of end-stage renal disease resulting in dialysis. Not very many. Nobody started on lithium after 1980 and ended up on dialysis. Nobody. And so, I'm worried my patient is going to be on dialysis. There's no reason in the modern Western world this should ever happen. You have a competent group of people yourselves who are monitoring assiduously. We often stop it too early. Creatinine's going up a little bit, and they stop it too early. But these days, lithium as a cause for dialysis should never happen. And as they say in this country, they haven't seen it in decades. I haven't seen it either. We're so good about monitoring, and as psychiatrists, we're so anxious about things. We often stop it maybe a little bit early, but very early too late. Another thing is about when to stop it. That's always the judgment call. Is the GFR, at which I would say this is the end of your time on lithium. It's time to move to something else. From that paper, and you can see after 1980, actually the graph cut off. These are all the people and their start dates on lithium, and the 32 people who ended up on dialysis. And you can see the last date was 1980. So people wonder if they've forgotten to put the date in there. But that person in Sweden ended up on dialysis who started on lithium in 1980. Then the number is 0. And in the US, probably the number is close to 0 as well. Okay, so you're put this on lithium, they're doing great, they don't have a lot of other side effects, you're managing it the same, and I'm seeing a lot. So, study which looked at people who had been on lithium and switched them to single daily dosing. So these folks, unfortunately, were started on BID or TID dosing. It is unfortunate because I know none of you will be that anymore. They switched them. They said, okay, I've seen the light, I heard the lecture, I'll switch them all to once daily dosing. Is it decreased their urinary volume? And it turns out it did, mostly for those people who had been on lithium for 5 years or less, technically less than 5 years. So the people on lithium less than 5 years, it didn't make a difference. Was the decision not to switch the other people? No. What harm can it do? Plus, it makes the experience, it makes everything easier for everyone else. So I will encourage everyone to switch their folks to once daily lithium, but you'll most bang for your buck in terms of polyuria if they're relatively early in the course of lithium exposure, less than 5 years. Treatment. So a nice analogy of lithium as a party gas. They get in the door, they crowd out your sodium, they inhibit your GSK every day, you can't get them out. So how do you manage your party? You hire a bouncer. What people do. People coming in the front door, and who bouncer we're going to hire? His name is a Miller. The Miller blocks epithelial sodium channel. This is its mechanism of action. By epithelial sodium channel, you guy at the front door with a velvet rope, and lithium gets in. You get in some sodium either, and so one of the side effects of a Millerite exposure, if you weren't lithium, would be sodium wasting, which you'll have cancer for. because if you waste sodium, then your lithium go up. And so you're on a milleride, it might but that's the mechanism of action. There's data on hydrochlorothiazide, which works by a somewhat similar mechanism at a slightly different site on the panel itself. But most literature is on imiloride. And so, it works, and I'll show you how well it works. 7 people, middle-aged folks on lithium for 20 years, their mean urine osmolality was 300, so they had full nephrogenic diabetes insipidus. Lithium levels were all very reasonable. This was crossover, double-blind design, 6 placebo or milleride, 6 weeks one, and 6 weeks of the other. And you can dose of the milleride, 5 grams a day for 2 weeks, going up to 5 BID for 4 weeks. Okay. Within time, we had a 165% increase in the urine osmolality. That's in that time. And you have doubling of the aquaporin 2 channel density. This is only at 6 weeks at a fairly less dose. No changes in the serum lithium level. Treatment of choice. We will monitor people on a milleride is early use. You'll first check their sodium and their lithium level. Then after a number of weeks, you'll repeat their osmolality, and then you'll see the improvement. Most people go at least 50%. Some people will have doubling or even tripling of their osmolality. We can tell you there's a big decrease in the amount of urine they're putting out during the day. So on a milleride, if it's going to be a long-term thing, you want to keep track of their sodium, keep track of the lithium. You may end up checking the sodium and lithium levels a little more often because they'll waste sodium. That's the mechanism of the drug. And if you're wasting sodium, what's going to happen to your lithium level? It might start drifting off a little. So a little more often, especially in hot places where our patients are, because they have other insensitive losses of sodium, just from sweating and things of that sort. But this is a great strategy. It's safe. It works well. You do have to be careful, though, if you're adding a milleride in the presence of other types of agents like ACE inhibitors or other distal tubular drugs. And don't just do this yourself. Talk about it with your med-surg physician. And if the person is on a drug for which there's a unique interaction, they can switch them to another type of antihypertensive or diuretic so you don't have a significant interaction that causes hyperkalemia. Okay? So the most important thing is that as a psychiatrist, I've ordered this and I feel comfortable doing it, but we work in a cooperative setting where you have somebody who's managing the hypertensives and the diuretics, and so we go to them with this information and say, I think a milleride would be useful here because the guy's osmolality is 200, he's peeing over himself, but can we switch some of the other medicines so we don't make the guy hyperkalemia? Come to a decision there. Well, if you ever collect their urine in large jars, consider it when they have a lot of polyuria. The nephrogenic BI on the basis of osmolality is really the way to track it. If so, and the person complains, then start the model. Some people say, well, I don't know, I go, it's not that big of a deal. And, that's fine if they say it's not a big deal and you believe them. But all will complain, or, some of our people are impaired. They won't complain until you bring it up, and they will complain. Not because you want them to be in the lithium for a long time, one thing which might allow them to stay on lithium successfully. So, and I give you the monitoring because of sodium wasting, monitor their lithium levels acutely as well as chronically, a little more often than you would otherwise. But great evidence-based, works well, very safe when used appropriately as long as you make sure you're not going to have interaction with the other medications for long. So what if I just stop the lithium? If they really need it, you probably can't do that. But if you do it, you'll see a change over a short period of time. But this is a short-term study, so I'm not sure what to make after 9 weeks. Over time, you will see some stabilization. And so the Israeli group, which published 114 patients, among those who did have significant creatinine, had improvement or stabilization when the creatinine was in the high normal range. And so if you want to extrapolate this estimated GFR, you would say if GFR is 60 or above and you stop your lithium, things will be fine, maybe they even get better. Smaller people had some non-significant increases, and some people actually had further declines. The question is, who are these people who are getting worse when they stop their lithium? What is the issue? So our group actually published also a large case series of people who've been on lithium for 20 years, in whom they stopped it. So creatinine clearance, which maps very closely to estimated GFR as a number, they found most of the people when the creatinine clearance was above 40, if they stopped lithium, things were fine and actually got better. Okay? But creatinine clearance was less than 40. Some of these people were starting to get further declines, and if it was below 25, it was really not good. And so, based on this, my general rule of thumb is that as people's estimated GFR starts to get below 60, you have to have the conversation with them about maybe your time on lithium is getting short. But continue to treat people until the GFR to get below 50. So that you're getting pretty close to 40. Your therapeutic index is narrowed significantly, and that's why I will say time to switch you off. Now, I'll bounce around in that range of 50 to 70, sometimes for years and years. So just the number is 50. Don't think, oh, well, that's close enough to 49. It's not 40 yet. And it'll dry, whatever. I'll say, look, drink water. And I'll check again and keep your kidneys hydrated. And if they can get in the 50s, I'm fine with that. But what is, you'll see very clearly that at some point they start to dip significantly below 50, and then it's the time to go ahead and transition them to something else. Don't cut immediately. You know, if they're going to need a mood stabilizer and you want to switch them to Depakote, get the Depakote therapeutic, and you can taper off the lithium over a period of days and weeks. Okay, don't just take away the lithium and watch them become mad. You know, getting on board first, and then you can taper off the lithium. So, SGFRs, calculate them if your lab doesn't give you. This is the calculator which I use. Sometimes you go on online calculators and they use millimoles for creatinine, which is not how our labs report the units. So I like it a lot. The things you need to know are the creatinine, the age, the gender, and whether or not the person is African American. Because those variables which it will ask you. Things are unreliable. So sometimes somebody will be 60, sometimes they're 80. But over time, you will see an obvious trend. And as you start to get to that magic number of fee, you know, you're going to have the conversation. But below 50, that's the time where I say, you're off lithium. It's unfortunate. I like to keep people on forever, but there's going to be a group of people for whom it's just not feasible or safe. And that's why I use. Below 50, that's the code. What do you want Depakote? And we'll taper off the lithium and go on from there. So to summarize, you know, give people lithium once a day at bedtime. It seems to be just effective as multiple daily dosing and causes renal side effects. Let's say check your parameters every 6 months. Occasionally, you might check lithium more often if it's according to this one author, very conservative. But you have people, let's say if they're on a Miller ride or GFR is getting a little low, you might end up checking more often. That's fine. Its GFR is 30 to 59. Well, let's put this way. If they're at 30, they shouldn't be on lithium anyhow. But certainly if their GFR is 50, 69, I'm probably checking these people a little often anyhow. And you know, that gives you some parameters for some extra tests. But I really think the most important thing is monitoring. And once a day. It's effective as multiple daily dosing with less renal dysfunction. The majority, so 79% at lithium, the only changes in GFR will be those related to age. Okay, but 21% for whom you will see more than you would expect. These will often have other causes of renal dysfunction, such as hypertension. But you know, there are some people for whom you may have to take them off of lithium after many, many years. But nobody in modern American medical practice should end up on dialysis. It simply doesn't happen. And in Sweden, in 34 years, and I doubt it has happened in the U.S. very often, especially monitored so assiduously. And talk about this with people, even among your colleagues. Don't talk about lithium causing renal failure, lithium causing renal dysfunction, because nobody's ending up on dialysis because of lithium. And again, polyuria, you know, they're all on once daily dosing. If the problem, you know, monitor it with urine osmolality and maybe treat it with a Miller. Lithium still presents the best therapeutic option for people with a bipolar diathesis, especially bipolar 1. We know suicide are high. Lithium has suicide reduction properties greater than any other mood stabilizer. but you know how to manage it. It's like clozapine. It has wonderful properties. Clozapine is a complex agent. You have to know how to manage its adverse effects. The same with lithium. You know, those who I see, who I think are the most experienced and are doing what they do, the people on clozapine, and they have a lot of people on lithium, and the people who are really sure they're at the top of their profession. And of course, you know, as we always say, if you have folks, when you have unusual things like the poor gentleman in the Tadero who developed a cardio on therapeutic lithium, you know, unusual case, you know, give me an email, you know, I'll always give you some advice on other options or what we think is going on. You know, we always see unusual things here. That's one of the fun about being in this setting. But never hesitate to contact us if you have questions. You know, we're here to help. So stop, get a little sip of water, and then we'll take some questions. So thank you all very much. And we will. So the question, compared to those on extended release preparations or multiple daily dosing, on single daily immediate release lithium levels have, and the difference was lower 24-hour urine volumes, so they less polyuria. So the answer is D. Evidence from the data we have about other parameters, multiple daily doses, definitely polyuria. Okay? So the following parameters of renal function remain stable, exhibit only expected age-related declines in your follow-up studies of people newly treated with lithium. The answers are A, E, creatinine, GFR. These are really stable over long periods of time. As I say, even with decades of exposure, about 79% of people will have just age-expected changes in GFR and creatinine. So things which tend to remain very, very stable, except in a small fraction of people, maybe a small fraction, 21%. So the correct answer is D, G and D. And then the last one, long-term follow-up study published in Israel, mean exposure 16.8 years. The people who exhibited clinically stable age-expected increase in serum creatinine was, let's say this number, 79%. So this is 80% of the people you can keep on lithium for long periods of time. They have polyuria, but they should not expect, you should expect anything more than that, and then you have to manage the polyuria. So last chance to see if there's any local questions. No questions here. Anything online? Okay. So everybody have a Wednesday afternoon, and we'll see you all next week. Bye.